We shall now go on to the other person on the opposite side debating, Dr. Arun Samprathi, who's the director of the Samprathi Eye Hospital and Spin Center and a very popular person in the field of strabismology and in pediatric ophthalmology. And he's going to tell us that adjustment is just a hype and we need to stick to conventional. So let's hear from you, Dr. Arun.
Thank you very much, madam. First of all, thank you for giving me this opportunity. So the internet itself has given the thing that Jitendra signals are not good, and so adjustable is not the procedure of choice. So I'll just tell you why fixed suture surgery is more important and more reliable. So fixed strabismus surgery or the non-adjustable suture surgery has been practiced by 95% of the strabismologists all over the world. Very few surgeons actually practice adjustable suture. So that itself is a major evidence for you to prefer non-adjustable over adjustable. So Dr. Jitendra has been hanging the muscles on a loose knot and then checking the alignment after 3 hours and he's adjusting the knot. This is what is adjustable suture surgery. The major presumptions here is one is the post-op alignment on day 1 is the final result. And number 2, muscle will get attached wherever he wants it to get it attached. Suppose you are doing a 9 millimeter incision, muscle is going to attach at 9 millimeters. So we'll see why this is not true. So this is a picture like many of the patients on the first day after the surgery or even after 3 or 4 hours after the surgery, eyes will be red, there'll be chemosis. Patient can hardly open the eyes. So how can you judge your alignment after having so much of inflammation in the eye? So your judgment itself may not be correct. So you're aligning the eye based on this judgment. And we know that there are a lot of post-op drifts, which is possible. And Dr. Jitani has also highlighted that it's possible the day 1 alignment is not the final. So we have many studies which have shown that at the end of 3 months, you can see in this particular study, the adjustable suture surgery, which had 90% success rate on day 1, had dropped to 50% at the end of 3 months. So the long-term results are really questionable. And the third thing is Dr. Jitendra is hanging the muscle from the cliff. So he's just putting the muscle there and he's thinking that it will get attached wherever he intends it to attach. But unfortunately, it doesn't happen, especially in long recessions, more than 6 to 8 millimeters. Invariably, the muscle will creep forward, leading to undercorrections. There are a few other problems associated with adjustable suture. Dr. Ravichandra sir has very nicely highlighted what are the risks of anesthesia. And my friend Dr. Jitendra wants to put the child under GA after 3 hours again. So definitely it is a risky proposition. And plus, this is so stressful for the patient to again go to the operating room, discomfort in the patient, and sometimes you may have vasovagal responses. There's doubling of the OT time and increased expenditure for the patient. And God forbid, if something happens, he has put it from the cliff, and suppose if this rope breaks, you're drowned. So this lost muscle is a dreaded complication of adjustable suture surgery. Besides, you may have problems like the conjunctival cyst or granulomas. And there are a lot of scientific evidence to prove that non-adjustable is better. So this is one of the studies where a lot of studies have been done. And how many patients, suppose if you put a patient on adjustable, how often you need to adjust because your nomogram is not correct. So Pratt Johnson and al. Has reported less than 50% of the patient actually required adjustment in the post-operative period. And some studies have reported even lower figures. There have been studies, in fact, this is one of the nice review published in February 2020, adjustable versus non-adjustable sutures in strabismus surgery, who benefits the most. And here they have analyzed different various studies available till date. And they have found that most of the cases, statistically, whatever the success rate which has been reported has not been very significant. So it is the difference between the adjustable and non-adjustable final alignment after 3 months has no big difference between the two groups, and statistically the differences are not very significant. So these are the various studies which highlight the same. And there's another nice review from the Cochrane study. Again, this group has analyzed various studies which are available about adjustable and non-adjustable. And they have finally said that the reliable conclusions cannot be drawn concerning which technique produces a better long-term alignment or in which condition one technique is more appropriate than the other. So they have not been able to say. In fact, they have been told that there is only one study so far, that too with the small numbers, which has shown that adjustable is superior to the non-adjustable technique. And hence they have concluded that there is no evidence to say that adjustable is superior to non-adjustable surgery. And I would like to conclude my argument by quoting one of the renowned ophthalmologist, Dr. David Hunter, who says, intellectually, it seems logical that having a second chance to improve the outcome of strabismus surgery should increase the overall success rate and reduce the reoperation rate. Yet, adjustable suture surgery has not gained universal acceptance, partly because level 1 evidence of its advantage is lacking, and partly because the learning curve for accurate decision making during suture adjustment may span a decade or more. So my friend Dr. Jitendra is probably a very expert surgeon, and probably he has mastered this art. But I don't think everyone should fall for the rosy picture Dr. Jitendra has painted about adjustable suture surgery. Stick to non-adjustable, the triumph proven method, and the method which is followed by 94% of the strabismologists. Thank you.
Thank you very much, Dr. Arun. That was a good punch you gave. No, sadly, Dr. Jitendra's, I hope his network has become all right. Then how do you deal? Is there something like, how would you deal with a refractive surprise if you do not use this small tool which is there in your hands? You don't need a tool if your measurements are so accurate all the time?
Yes. Basically, it depends on our nomograms, madam. So I think most important is to be confident about our nomograms. What is the results that we are getting in particular surgeries? So if you are confident about it, I'm sure probably will not need that.
Sir, you don't prefer handbags in post-RD surgeries with the buckle also?
Yeah, probably you have to use a non-adjustable suture there so that the suture doesn't break and you don't drown.
Jitendra sir, how much percentage of your horizontal muscles like you need to readjust? Especially in case of intermittent exotropia, if you're doing adjustable, how much percentage of your patients need real adjustment?
You're asking me, ma'am?
Yes.
Yes, sir. Yes.
Oh, I'm sorry. I didn't get. No, I don't do adjustable and intermittent exotropia, madam. I don't do intermittent exotropia. I just do because most of the cases, my argument was not that adjustable should be done in all the cases. I actually meant that there are specific indications. Most of the studies which Dr. Arun sir quoted were true and just. The only thing is that all the studies which have been done are head-to-head studies with intermittent exo patients or horizontal muscle surgeries. Adjustable is a surgery of choice only in specific indications. That is what I do. So in routine cases, I don't do adjustable. There were some questions in the chat box about pediatric cases and adjustable. Most of these patients were already operated. They were resurgeries. Patients were really bothered and concerned what will happen. And most of these cases were infantile esotropia, both eye MR recession, already recessed, and they went into either consecutive exo or they were exo-operated patients. So most of my patients are post-op resurgeries, thyroid, diplopia patients. I have honestly not many patients I have done in intermittent exotropia where I have done adjustable surgeries.
Would you recommend adjustables in thyroid eye disease?
In almost all the thyroid eye disease, I would go for adjustable because we are really not sure what will happen post-op. This is most of us, I know Dr. Arun and most of the panelists would agree that in most of the patients, we would plan to go for adjustable or at least semi-adjustable. If we are doing inferior rectus recession, I would not like to go pure hangback. So I would do a fixed suture and put a semi-adjustable technique of Spielman, or which was popularized by Kushner later.
Okay, so shall we go on to our next speaker? That was a good set of debates and.
Can I just add one point, ma'am?
Yes.
You see, I have done some adjustable, but direct peroperatively, where I stuck the Snellen chart on the roof, and I even got the goggles, sterilized and under topical anesthesia. So we could actually do a cover test, with the chart stuck to the roof. And I had a similar thing in the clinic, so that we practice with the patient, so that he or she would understand what is expected during the surgery. But of course, I still believe that it doesn't make a difference. The outcomes were pretty much similar compared whether we did adjustable or we did fixed surgery. But having said that, I believe that there is a little space for it in those difficult situations that Dr. Jitendra pointed out.
Yes, sir. I think that's the advantage of getting used to topical anesthesia.
Yeah,
Yes.
correct.